here's kind of that example here. So we can use that color Doppler, and we can see, well, we've got pretty significant amount of regurgitation here. We've got some artifact that's shining down from that bright near field calcification, so we get a little bit of reverberation that's running through. We've got significant aortic valve disease, and then we've got both stenosis and regurgitation here as well. So we've got a lot of things going on with this patient. Unfortunately, this is a status post radiation patient, which this is one of the unfortunate things that we see from someone who's had a ton of radiation, ends up getting the valves, ends up getting the coronaries, and here are those Dopplers. So very similar Doppler pattern that we kind of looked at in the previous example. So we can use this to quantify what we're seeing visually. So if we look, we've got a Vmax through the aortic valve of about almost 4.2, so a mean of 42. And then we've got a pressure half-time of 377. So we've got a very strongly severe aortic stenosis here from a velocity standpoint. And then we've got what appears to be a very strongly moderate pressure half-time. Basically over 500 is considered mild. Anything under 200 is considered severe. So we've got a strongly moderate aortic regurgitation that is probably bringing our velocities up through that aortic valve. But most likely we've probably got, in this case, this would kind of tip us more towards the aortic stenosis being the bigger problem. Either way, the valve needs to be fixed. It's just a matter of what's the reason that you're fixing it for. And in a case like this is a patient that you could probably get a TAVR because it's better indicated because of the calcium burden and because of the stenosis severity. And if we look at the short axis and we look at the function, we can see from a short axis view, there's really some definite, verification of what we had thought we had seen from those Dopplers, right? So here's our aortic valve opening, and we've got, pretty much next to nothing. So this is certainly a valve area that's probably going to be less than 1 with a fairly preserved function. But also, the other thing that you can look at from the ventricular side is what? Well, what do we have? If we have one that's more severe than the other, visually, what can we assess from that left ventricle? Well, if we've got a higher amount of chronic aortic regurgitation or a higher amount of chronic aortic stenosis, those are two completely different loads that are on the ventricle. So chronic aortic regurgitation is going to do what to the ventricle? Well, it's going to stretch it out, it's going to dilate it. So we're going to get eccentric remodeling. But here, what do we notice about the ventricle? Well, it's pretty thick, which means that we've probably had much more long-standing AS than we have the AI.